Hello. Hi. Good morning, students. So today's for the next 6 classes, I'll be taking on topics related to spine. So today's topic, the first topic of discussion is TB spine, otherwise known as Pott's disease. So I'm pretty sure why is it named after Pott. So it was first described by Sir Percival Pott. Okay, so can somebody tell me about? Uh, so do you know about? Sir Percival Pott's contributions. So Sir Pott has contributed lot in the field of orthopedics. So there is something called as Pott's fracture, which is otherwise known as ankles bimalleolar fracture. And then we have Pott's puffy tumor, which is nothing but osteomyelitis of the frontal bone. Then we have Pott's disease, that is tuberculosis of the spine, and Pott's paraplegia. And these are all the contributions of Sir Percival Pott. So now, TB of the spine is the most commonest type of osteoarticular tuberculosis because TB spine consists of almost 50% of the cases which contribute to all the osteoarticular tuberculosis. So considering the tuberculosis of the spine, so infection of the bones and joints is always secondary to a primary focus elsewhere in the body. So usually the primary, as all of you guys know, it's in the lungs. Okay, so the primary focus is otherwise known as the Gons focus. So usually tuberculosis of any bone in the body is secondary to a hematogenous spread or a venous spread from the lungs. So that's why it's always a secondary infection. So poor nutrition, poor sanitation and poor resistance are the predisposing factors. So now in this tuberculosis, there is no sex predilection. So male and female are affected equally, and of course there is no age which is resistant to this infection. So younger the age, obviously, since the bones are still in the developing stage, whether it's in spine or whether it is in any bone. So if it's a pediatric age group which has been affected by a tuberculosis, so obviously the damage is more because more the cartilage gets damaged, and obviously it will result in a deformity as the child grows and attains the skeletal maturity. So younger the age, more is the bony deformity. And obviously, so you would have all learnt about the pattern of infection in your pathology. So how does tuberculosis, tubercle bacilli reach the spine? So before that, we would obviously learn how the vertebral column develops. So obviously vertebral column develops from small paired cubical masses called somites. So the central midline in the embryo, in the 4th week we have something called as somites which develop from the notochord. So midline straight structure, cord-like structure, which further differentiates later on into somites, and these somites further differentiate into dermatome, a myotome and a sclerotome. So dermatome is nothing but that which gives rise to the skin and all the appendages, and the myotome is nothing but all the musculature which gets arising from that, and sclerotome is which surrounds the notochord, and each sclerotome condenses into a cephalic mass, caudal mass and a posterior element. Now this is important because the vertebra develops from here. So the formation of vertebra begins from these sclerotomes which would have condensed into a cephalic mass, caudal mass and a posterior element. So obviously, so what happens is this is the blood supply pattern. So if you remember, the blood supply of every vertebral body is like the lower half of the upper vertebral body and the upper half of the lower vertebral body along with the intervertebral disc in between. They all receive blood supply from the same segmental artery. That means you have two vertebral bodies with with an intervening disc in between. So you have two vertebral bodies with an intervening disc in between. So in this, the upper half of the lower vertebral body, then the disc which is above that, and the lower half of the upper vertebral body. So all these three structures receive blood supply from a common segmental artery, which is nothing but a branch from the radicular artery, which is obviously arising from your aorta. So now what will happen is, why is this important? Now what happens is, this is the blood supply, that is the arterial supply. But the venous system is bit different. The venous system for every vertebrae is one vein which drains from the entire vertebral body and then goes and drains into the Batson's plexus of veins. You know the speciality of the Batson's plexus of veins. So the Batson's plexus of veins are totally valveless veins, unlike the veins in the lower limbs or in the upper limbs which have valves. So these valves always prevent, why are the valves there? They help in the unidirectional flow of blood, because the vasculature in a vein is thin due to the absence of the tunica media. So what happens? There is no effective pumping of the blood in these veins towards the heart. So these valves prevent the backflow of blood, hence facilitating the flow of blood through towards the vena cava and then entering the right chamber of the heart, right atrium. So now coming to that, so the arterial supply, like I don't have an image of that, the arterial supply of the adjacent vertebra is from a segmental artery. However, the venous drainage of every vertebra has a single vertebral vein. Now as we see, this is what I was telling. So blood supply follows the embryonic pattern. So each segmental artery in the vertebral column supplies lower half of the upper vertebra, upper half of the other caudal and the cephalic mass, and hence the intervertebral disc or the nucleus pulposus, which is developing from within these segments, between these two segments, between the caudal and the cephalic mass, is also developing blood supply from that same segmental artery. Now what is the problem? Now if a tubercle bacilli which is getting lodged in this segmental artery gets stuck in those segmental artery and obliterates the blood supply to that particular vertebra. So what are the vertebrae which are affected? It will be upper half of the lower vertebra, lower half of the upper vertebra, and the intervertebral disc space, which will go in for an ischemia and necrosis due to the segmental artery being blocked by the tuberculous bacilli. So following that, what will happen? There will be ischemia, there will be infarction. So obviously what will happen? There will be necrosis. So the vertebral body, all of us know that it is made up of cancellous bone, okay, spongy bone. So obviously the vertebral body will collapse, lower half of the upper vertebral body, upper half of the lower vertebral body, okay, and the intervertebral disc in between also will undergo necrosis. But the intervertebral disc basically depends on the nutrition from the end plate, from the adjacent vertebral bodies. Hence the intervertebral disc is the last to undergo necrosis in a tuberculosis. Okay, in a pyogenic discitis, that means non-tubercular infection of the spine, the intervertebral disc usually fails soon, and the organism is usually very virulent, unlike a tubercle bacilli which is slow growing. So usually there will be some amount of diffusion still happening, whereas in a pyogenic bacterial infection of the spine, the necrosis happens fast, and the disc disc necrosis faster when compared to the tuberculous infection. Hence nucleus pulposus, obviously all of us know that intervertebral disc has two components, that is the outer annulus fibrosus, which is tough, resilient, and the inner part of the intervertebral disc is called as the nucleus pulposus, otherwise known as the jelly like thing. So it is this nucleus pulposus which, when herniates, by a breach in the outer annulus fibrosis results in intervertebral disc prolapse. Okay, so the nucleus pulposus is always being contained, well contained in the by the annulus fibrosis, but this annulus fibrosis, because of various reasons, because of trauma, because of some defect, it can leak out this jelly like structure, otherwise known as the nucleus pulposus, which results in causing herniated nucleus pulposus or intervertebral disc prolapse. Okay, so now in a classical lesion of tuberculosis TB spine, it shows the importance of the embryonic blood supply, because infection always involves the lower half or the upper half of the vertebra, manifesting radiologically as narrowing of the disc space, also dissemination of the infection occurs through the bloodstream, that we all know. Now coming to the clinical features, now this was regarding the pathology. I am pretty sure you are all aware about the type of organism, acid fast bacilli, and I mean obviously how how it's detected and what is the culture media. Okay, we'll be coming later on to that for the lab investigations. Now coming to the clinical features. Clinical features, now back pain in spine, back pain is the earliest and the most commonest symptom. So you look at any patient coming with back pain, don't think that they have TB spine, but usually a back pain which is chronic, which is insidious, slow onset, going on for long duration, needs to be considered. So any backache which is more than 6 weeks, you will have to consider it as a chronic backache. And then when it goes beyond 3 months, it definitely needs to be evaluated. So pain is usually dull and vague, and initially and very rarely it goes on to become severe and constant. And then it will usually be aggravated on movements of the spine, because obviously if you all know that spine is the most important thing in helping us to stand erect. Now because there is it's a mechanical support, isn't it, to the spinal cord. So obviously any movements which get worsened on loading the spine, like sitting up, standing, jogging, would obviously is obviously resulting because of the mechanical instability. So when the spine undergoes mechanical instability, it will obviously result in backache and discomfort, because the spine is unable to take up the load of your upper back and the skull. So obviously patient usually has pain in the mid back, because that's the most commonest location. Thoracolumbar spine is the most commonest location for tuberculosis of the spine. The reasons, I'll be enumerating it in a few minutes. So basically the reasons being, because earlier reasons were thoracic spine is more of kyphosis. The thoracic spine is in a kyphotic position, and lumbar spine is lordosis. So the two primary curvatures of the spine, and we have two primary curvatures of the spine and two secondary curvatures. The primary curvatures are thoracic spine and sacrum, which are both in kyphosis, whereas the cervical lordosis and the lumbar lordosis are secondary curvatures. Means when a child is born, the child has only two curvatures, that is inside the mother's womb. So child has only thoracic kyphosis and sacral kyphosis. But as the child starts to, child goes on his feet, the secondary curvatures develop to maintain an erect posture, that is cervical lordosis and lumbar lordosis, to maintain the balance of the thoracic kyphosis. So why thoracolumbar spine is the most common, thoracolumbar spine or the lower thoracic spine is the most commonest site for TB spine? Yes, because of the transition of the kyphotic thorax with the lumbar lordosis. So whenever there is a transition, that area is more prone for stresses. So there is a constant amount of stress happening at that area because of your change in the mechanical axis. Second, the cisterna chyli, which is the main lymphatic drainage system, which is located at the thoracolumbar junction, usually at around D10, D11 vertebra on the left side. So that was also proposed to be a foci of the main lymphatic drainage. So it was thought that because it was a main, you have a lymphatic sac there, and the typical bacilli getting seeded, and from there it used to spread by diffusion into the vertebra, and then secondarily affecting the vertebra. And the third most thing is the vertebra at the lower thoracic spine are usually very soft, and hence are very prone for infection, and they are also highly vascular, hence that area is more predisposed to infection. So these are the various reasons why you have thoracolumbar junction as one of the most commonest reasons for TB spine. So coming to the clinical features again, so you might not see classical constitutional symptoms which are like loss of weight and appetite and evening rise of temperature in a osteoarticular tuberculosis. So this is usually seen in pulmonary tuberculosis. So osteoarticular tuberculosis, you may not see the classical constitutional symptoms which are significant weight loss, that is 10% of the body weight loss in 6 months, and a classic evening rise of temperature. I am pretty sure you guys are aware of the fact why do you have a evening rise of temperature, because of the low steroid levels in the body. So at morning you all of us have a 8 a.m. cortisol surge, following which the body's stress handling capacity is very well, but as the day progresses your steroid levels are low in the evening, and that is why you have usually the fever is well picked up in the evening. And coming to the neurological symptoms, which is the other clinical features, very important clinical features in the in TB spine, that always also has to be looked as a very good clinician usually picks up a myelopathy by an extensor plantar response even before the patient complains of weakness in both limbs. Okay, so when a lower thoracic spine is involved, compressed, so obviously it will result in myelopathy, and that will obviously result in compression of the spinal cord, and patient would develop paraparesis, spastic paraparesis, and obviously patient won't say that I have paraparesis or weakness. He'll say I have developed some amount of tightness of the limbs, and when you examine him, and you will find that there is a extensor plantar or a Babinski is positive. Okay. Now coming to the last, the one more clinical features which is important is of the paraspinal spasms. Now why do you get the paraspinal spasms? So you have two powerful extensor muscles which are erector spinae on either side of the spine, and also multifidus. So you have two each on either side. So obviously that will usually help in taking up the load of the spine. Now once your mechanical or the bony stability of the spine is lost, these muscles are being loaded because the spine is not taking up the load. Hence these you will find the paraspinal muscles which are very taut, otherwise they would be in a state of spasms. Okay, now coming to the examination findings. So the typical gait of a TB spine patient is called as the alderman's gait. So who is an alderman? Alderman is a tax collector in UK. They have a typical gait of their, the shoulder being, braced backwards, head held high. Now usually this was the most topmost qualified job in the UK, and they had a pride when they walked in the along the streets of the in UK. So that classical attitude is also seen in TB spine patients. Now here TB spine patients have this gait not because of their attitude, it's because of the pain and the spasm. They don't want to jerk their spine. So basically they don't like to have any kind of jerks, so they walk with so much of care and caution, and that is why it's called as a classical alderman gait, which is nothing but small steps with straight back to avoid jarring. Now coming to presence of gibbus. Now this is something very important which most of the students have confusion always. Now kyphosis of the spine can be of three types. Okay, so you remember it as remember it by the mnemonic KAR. So car, K is knuckle. When you have a knuckle is when you have a single vertebral body collapse. You call it as a knuckle kyphosis. Angular when you have two vertebral body collapse, and rounded when you have three or more vertebral body collapse. So KAR is the mnemonic for kyphosis. Now what is gibbous? Gibbous is other name for angular kyphosis. So kyphosis can be knuckle, which is single vertebral collapse, angular, or gibbous, which is two vertebral collapse, and rounded, which is three or more vertebral collapse. Okay, so very clear. Now third examination finding is when you have a spine, a tenderness over the spine. Now, tenderness of the spine can be elicited by a couple of methods. So, one is when you directly thrust your hand over the spine, that is just to see if there is any tenderness, or else you can give pressure over the spinous process by with your thumb. So, that is called as a rotatory spinal tenderness, and that's called as Holdsworth test. HOLDSWADTH. So Holdsworth test. So that is basically to see the rotatory instability. So you basically place your thumb, the examiner places his thumb on the spinous process and just gives a rotatory motion, tries to push it to either side, either right or left, and if the patient has pain, it is positive of that. So Holdsworth test is positive. Normally all of us have a negative test, but in these patients where the vertebrae are destroyed or the posterior elements of the spine are also involved, then it will be positive Holdsworth test. And then we have the presence of cold abscess or the swelling or the sinus tract, which is visible when with discharging sinus, discharging pus. And then a classical patient with cervical spine may support the chin over the palm of the hand with stiffness, dysphagia, or stridor. So why does a patient with cervical spine tuberculosis hold the chin over the palm? So that is because the entire load of the skull, which is on the slender cervical vertebra, now because of the tubercular infection of the cervical spine, the vertebrae are unable to take up the load of the skull, and even in the neck the muscles are all they're very thin and they're not strong enough to take up the load of the skull, unlike your back muscles. Hence the patient gives the support of your hand under the chin just to offload the weight of the skull. And why you will have dysphagia? Because obviously abscess in the front of the vertebral body, cervical vertebral body, will compress the esophagus, because the esophagus is right in front of the vertebral body and behind the trachea. So once the esophagus is compressed, it will result in dysphagia and to both solids and liquids, and then you will have stridor, which is secondary to compression on the trachea. So when this patient presents with stridor, it's a medical emergency. Patient who should, if not treated, would get arrested. Coming for what? Cardiac arrest. Coming to the investigations, so obviously all of us know that it's you need both a lab investigation and the radiological investigations. So lab investigations, I'm pretty sure you'll have a low HB, and then we'll have a moderate increase of the total count, and in a differential count you would predominantly see the lymphocytes which have increased, ESR which is also raised, a MAN2 test, which reading with the reading done in after 72 hours would tell you would give you an idea of whether its patient is infected or had a infection in the past with the BCG or immunized. So now score of more than 9 mm is positive, whereas a score of 5 to 9 is 5 to 9 is indeterminate, and less than 4 is negative. Now what is important in this? Is it just the size or is it the induration? So that is more important. So induration needs to be measured and after the 72 hours. Now ELISA for antibody for microbria, myco, mycobacterium also can be done, or else the recent way is we do a PCR, TB PCR. Okay, so the benefit of a PCR is it would pick up even a dead bacilli. So a dead bacilli also could be picked up on by a PCR. So hence and obviously it is more sensitive. And the common staining which we use is the Ziehl-Neelsen staining from from a sinus or abscess or whatever it is. And then coming to the radiological study, I think this we can have it in the next class. We'll start off from the radiological study. So any questions you can post it on the okay, post it on this thing, or you can directly WhatsApp me. Okay, thank you so much. See you on Friday. Have a great day. Thank you.